Welcome to lecture kanski lecture series, and we are going to start Cornea part 4. And today we are going to discuss about the bacterial keratitis. So what is a bacterial keratitis? Infection of the cornea is called keratitis, and if the infectious cause is bacteria, then it is called bacterial keratitis. So, what is the pathogenesis of the bacterial keratitis? Pathogens. Bacterial keratitis usually develop only when the ocular defenses have been compromised. So basically the epithelium is very important. If the epithelium is compromised or there is an abrasion, then there is a chance that the bacteria get invaded. Otherwise bacteria do not usually cause infection, but there are certain types of bacteria that can penetrate through the intact corneal wall. So what are these bacteria? Let's see. However, some bacteria including Neisseria gonorrhea, Neisseria meningitis, and Corynebacterium diphtheriae and Haemophilus influenza are able to penetrate a healthy corneal epithelium, usually in association with severe conjunctivitis. So we are going to make a mnemonic indent. What is indent? That they indent the corneal epithelium. So I is for Haemophilus influenza, and N is for Neisseria gonorrhea and Neisseria meningitis, and D is for Corynebacterium diphtheriae. E and D enter. So this is the mnemonic for it, and they are usually associated with severe conjunctivitis. It is important to remember that infection may be polymicrobial, including bacterial and fungal co-infection. So what does it mean? Microbial mean multiple bacteria can attack the cornea at the same time. This is called polymicrobial. And if the fungal co-infection, and it can be associated with fungal infection as well. So bacterial plus fungal as well. Common pathogens include Pseudomonas aeruginosa. It is a ubiquitous gram-negative bacillus rod, commensal of the GIT tract. So basically, these organisms are generally present in the GIT, where they are usually normally present. The infection is typically aggressive and is responsible for about 60% of the contact lens related keratitis. So, how does it cause? It is caused by the contact lens related infection. It is one of the common infection. Next is the Staphylococcus aureus. Staphylococcus aureus is a gram-positive and a coagulase-positive commensals for the nares skin. Nares means nose, skin, and conjunctiva. So these are usually commonly present around the nose, skin, and along the conjunctiva. And what does gram-positive mean? Gram-positive mean that if a bacteria, so there is a crystal violet stain. If the bacteria takes up the crystal violet staining, it means that they are gram positive. If they do not take the color of crystal violet, then they are gram negative. So it is a gram positive, means that they are purple in color, whereas gram negative are in pink in color. Keratitis tends to be present with a focal and fairly well defined white and yellow white infiltrates. So basically the keratitis are basically present how with a fairly focal infiltrates in the cornea. Next is the Streptococcus. Streptococcus pyogenes is a common gram-positive commensals of the throat and vagina. Strep pneumoniae pneumococcus is a gram-positive commensal of the upper respiratory tract. Infection with streptococci are often aggressive. So basically the streptococci are pyogenes, and strep pneumoniae pyogenes is normally present in the throat, and strep pneumonia is present in the lungs, upper respiratory tract. Risk factors. What are the risk factors of the bacterial keratitis? contact lens wear, trauma, ocular surface disease, and other factors. So there are multiple factors that can increase the chance of the cornea to get the bacterial keratitis. So what are these? These are contact lens wear, very important because it is the most commonly used. So contact lens wear is very important risk factor for the bacterial keratitis. Contact lens wear, particularly if extended, is the most important risk factor. Corneal epithelial compromise secondary to hypoxia and minor trauma is thought to be important as it is bacterial adherence to the lens surface. So what causes the contact lens to be the risk factor for the bacterial keratitis? Basically, when the contact lens is over the cornea like this, so it causes tear, as you know that tears provide the oxygen to the interior surface of the cornea. So if the tears are not lubricating the eye properly, the cornea tends to become hypoxic. If the cornea becomes hypoxic, then there can be a minor trauma as well. So the bacteria can enter and invade the corneal epithelium. Wearers of the soft lenses are at higher risk than those wearing the rigid gas permeable lenses and other types. Infection is more likely if there is poor lens hygiene, but it can also occur even with apparently meticulous lens care and with daily disposable lenses. So basically, if there is a poor hygiene and lens hygiene, then it can also cause is a risk factor for the in bacterial keratitis, but generally any contact lens wear can cause bacterial keratitis. Trauma. Now what is trauma? Including the refractive surgery, particularly laser. What does the laser mean? Laser is assisted in situ keratomycosis. So this is a short form for LASIK. Has been linked to the bacterial infection. So anything which causes the trauma to the epithelium can cause the bacterial keratitis. So LASIK is also the risk factor, including with atypical mycobacteria. So LASIK is associated with atypical microbacteria. In developing countries, agriculture injury is the major risk factor when fungal infection should be considered. So basically, agricultural trauma can also cause bacterial keratitis, but it is usually associated with fungal keratitis. So fungal plus associated bacterial keratitis can also happen to be present. Ocular surface disease. Ocular surface disease such as hepatic keratitis, bullous keratopathy, dry eye, chronic blepharitis, trichiasis, entropion, exposure, severe allergic eye disease, and corneal anesthesia. So any general ocular diseases which cause the dryness of the cornea can cause this, like bullous like dry eye and entropion, exposure, and any lid surface diseases can cause the bacterial keratitis. Other factors include local or systemic immunosuppression, diabetes, and vitamin A deficiency. I'm going to highlight the vitamin A deficiency because it is very less rare associated, but it can be asked in the MCQs. Bacterial corneal ulceration should be excluded in a patient who wear contact lenses and present with a painful red eye and blurred vision. So whenever there is a contact lens wearer who come with you with a complaint of pain and redness and discharge, then you should definitely think about bacterial keratitis. So what are the clinical features of the bacterial keratitis? Presentation is with pain, photophobia. What does photophobia mean? There is an increased sensitivity to the light, blurred vision, mucopurulent and purulent discharge. And what are the signs? So what are the symptoms? Symptoms are basically what the patient present with, and signs, what do we see on the slit lamp and journal clinically is known as sign. We can see it is not usually that all of the signs should be present. Some of the signs can be present. An epithelial defect with infiltrate involving a larger area and a significant circumcorneal congestion. So there is going to be a significant circumcorneal congestion, and there can be an epithelial defect and infiltrate along it. We can see the figure 7.7a, which is showing that there is a whitish infiltrate and there is a circumcorneal congestion. Now on the slit lamp examination, we can see the different layers of the cornea. So we can also see the stromal edema in this case. As you can see that keratitis mean that cornea is infected. So cornea can present, corneal disease can present with in various shades. And so stromal edema can also be present. Folds in the descendant membrane can also be present, and anterior uveitis commonly with a hypopyon, and a posterior synecdoche in a moderate to severe keratitis. When there is a severe keratitis, it can also be associated with the anterior uveitis. Plaque-like capes can form on endothelium contagious with an affected stroma. So if there is an anterior uveitis, then capes can also tend to be present on the endothelium. Chemosis and eyelid swelling in moderate to severe cases. So we can also see the eyelid is also swelled up and chemosed. Chemosis means that there is a fluid retention in the conjunctiva or the eye. Severe ulceration may lead to so the corneal diseases can lead to complications now as well. So if there is a severe ulceration, then it can lead to descematocele formation, mean that there is a protrusion of the descendant membrane to the thinned out cornea. And even if perforation can also occur, particularly in the pseudomonas infection. So we are going to see figure 7.7 A, B, C, D, E. So A is early ulcer, B is, you can see, the large rounded ulcer, and C, you can see ulcer with a hypopyon. So they have arrowhead shows that there is a hypopyon, and C is showing the perforation of the cornea. Now anything can happen with, now we are studying about what if the severe infective keratitis can occur, then it can lead to complications like perforation, and then scleritis can also develop due to keratitis, particularly with the severe perilimbal infection. Endophthalmitis is rare in the absence of perforation, but it can happen. Improvement is usually heralded by a reduction in eyelid edema and chemosis, shrinking of the epithelial defect, decreasing infiltrate density, and a reduction in an interior chamber sign. So how can we say that this lesion is improving? We can say that AC reaction is decreasing, there is a decrease in size of the epithelial defect, and there is a lessening of the edema and chemosis. Subsequent scarring may be severe, including vascularization. In addition to opacification, irregular astigmatism may limit the vision. So post-operatively, post-infective sequelae, there can be opacification of the cornea, which can lead to the astigmatism, and that is why the patient can present with the lifelong corneal decreased vision. So, and other signs are reduced corneal sensation. Basically, reduced corneal sensation are in the viral keratitis. But if there is a reduced corneal sensation in bacterial keratitis, it may suggest that there is a neurotrophic keratopathy. What is a neurotrophic keratopathy? Neurotrophic keratopathy is basically when there was a ulcer that was due to the bacterial keratitis, but now the bacteria is removed because of the use of the antibiotics. Now it is sterile, so this become the neurotrophic keratopathy, and it is non-healing, particularly when there is no major risk factor. And neurotrophic keratopathy also means that due to the decreased corneal sensation, there is still a persistent ulcer. Sensation may also be reduced in chronic surface diseases like herpetic keratitis and long term contact lens wear. IOP should be monitored. Why IOP should be monitored? IOP should be monitored because of the associated anterior uveitis. If there is an associated anterior uveitis, we can also say that there can be a increase in the IOP. Now, what are the differential diagnoses of the bacterial keratitis? Differential diagnosis of the bacterial keratitis include keratitis due to other microorganisms like fungi, acanthamoeba, stromal herpes simplex keratitis, and microbacteria. Marginal keratitis, it is basically sterile ulcer, sterile inflammatory corneal infiltrates associated with contact lens wear, can also present like this. Peripheral ulcerative keratitis and toxic keratitis. Now we are going to study about the investigations of the corneal disease. Investigations of the corneal disease is basically corneal scraping, corneal staining and culture and sensitivity. So first of all, we are going to take the sample from the cornea. So how are we going to take the sample from the cornea? In this paragraph, we are going to discuss about that. Corneal scraping. This may not be required for a small infiltrate, particularly one without an epithelial defect and away from the visual axis. So it is not usually indicated to do the corneal scraping in all cases. Yes, we do in when there is a severe ulcer or there is a very serious disease that is presenting. But if there is a very small ulcer and that is also away from the visual axis, then we do not tend to do that. So how we do it? A non-preserved topical anesthetic is instilled. Preservative may lower the bacterial viability for the culture. So we tend to use non-preservative topical anesthetic. 1 drop of proximetacaine 0.05% is usually sufficient, but tetracaine may have a greater bacteriostatic effect. So you can use the corneal anesthetic drops. Then what we do? Scrapings are taken either with a disposable scalpel blade number 11 or Bart Parker, the bent tip of the large diameter 20 or 21 gauge hypodermic needle or a sterile spatula. So there are 3 things you can do to take the sample. One, you can do it by using the blade. Second, you can use the needle of about 20 to 21 gauge, and third, you can use the spatula. The easiest way to plate scraping without breaking the gel surface is with spatula, but the best method and easiest method is with the spatula, because it you can just plate the scraping. If a fresh spatula is not available for each sample, a single instrument should be flamed, sterilized between scrapes. Heat for 5 seconds, cool for 20 to 30 seconds. So you are going to take the multiple samples. So how are you going to take the multiple samples if you have a one spatula, for example? What you can do is you can take the sample and then heat it for 5 seconds and then cool it for 20 to 30 seconds, and then what you can use it again. Alternatively, a fresh scalpel blade or needle can be used for each pass. Calcium alginate swab may also be satisfactory. Loose mucus and necrotic tissue should be removed from the surface of the ulcer prior to scraping the margin and the base, except if very thin of the lesion are scraped. So what we do of the ulcer scraping, we take the margin and the base of whole of the ulcer, but if it is very thin, we tend not to do it on that side. So you can see the figure 7.8a. You can see the corneal A is corneal scraping. I think this is a blade that is being used to take the sample. B is, you can see the different culture media that is made, a chocolate agar, blood agar, and you can see how the colonies and bacteria are growing on the culture. So on Staph aureus is C is the Staph aureus grown on a blood agar forming a golden colonies with a shiny surface, and N. gonorrhea grown on a chocolate agar. So this is N. gonorrhea. Now we are going to study a thin smear is placed on one or two glass for the microscopy, including gram staining. So we tend to do 2 to 3 samples, and how we take 2 to 3 samples, we one is used for the glass slide for the gram staining. A surface is provided on one side of one end of the slide, conventionally up for pencil labeling. The sample is allowed to dry in air at room temperature for several minutes and then placed in a slide carrier. So basically, on one side of the slide, so this is a slide, and on one side, a name is one side is usually used for a pencil labeling. Re-scraping is performed for each medium and sample are plated onto the culture medium, and then we take about the different medias, culture medias, and we tend to put every sample different sample in each of the media, taking care not to break the surface of the gel. Routinely, what cultures are being used? Basically, blood agar, chocolate agar, and saboroids media are used initially, and then samples are placed in an incubator until transported to laboratory. Refrigerated media should be gently warmed to room temperature prior to sample application. So, if the any media that is usually refrigerated, you have to warm it and then put the culture media onto that. A blade or needle can be placed directly into the bottled media such as brain heart infusion. And alternatively, you can do that. Brain heart infusion is basically a liquid sample, and we tend to put a needle or blade in directly into that media. There is an evidence that a single scrape sent in PHI to the laboratory where it is homogenized and plated provides similar result to the traditional multi-scrape method. Scraping may be delayed without treatment for 12 hours if antibiotic have previously been commenced. Then what else? This is how we do scraping. Then we can also take the conjunctival swabs. Conjunctival swabs may be worthwhile in addition to the corneal scraping, particularly in severe cases, as occasionally an organism may be cultured when a corneal scrape is negative. Sometimes the corneal scraping came negative, so it is a good idea to take a conjunctival swab. Basically, we take a swab, and when then we take the conjunctiva, we swab through the conjunctiva and take that sample for the culture and sensitivity. So some organism may be captured in that swab. Cotton wool, calcium alginate, and synthetic swab have been found to have some bacteriostatic effect. Calcium alginate may be the best option. So there are various swab that is available: cotton wool, calcium alginate, and synthetic. So best of them is a calcium alginate one. So you can also culture the contact lens cases. Contact lens cases as well as bottles of solution and lenses themselves should be obtained when possible and sent to laboratory for culture. The cases should not be cleaned by patient first. So they can also be, contact lens cases can also be used to culture the organism. Next is a gram staining. Gram staining differentiate bacterial species into gram positive and gram negative based on the ability of the dye crystal violet to penetrate the cell wall. As I have told you how we differentiate between a gram positive and a gram negative, we say if we stain the bacteria with a crystal violet stain, if the bacteria takes up the stain, then this is gram positive. If it is not, then it is gram negative. So that means that gram positive is purple and gram negative is pink. Bacteria that takes up a crystal violet are gram positive, and those that allow the dye to wash off are gram negative. Other stains generally not requested at initial investigation are listed in 7.3. So we are going to study about the culture and sensitivity in the next lectures.